Hey guys, welcome to Second Opinion. I'm Dr. Trevor Eason, your host of this podcast, and what I wanted to do today is introduce Justin Slager, DDS, Dr. Justin Slager of Cookeville, Tennessee, Slager Family Dental. And I just want to say, it was a fun podcast. We talked about so many different concepts that most people don't think about. We talked about controversial things, the things that people should know, specifically adults and kids, when to get your kids in there, how important your oral microbiome is, how important some of the bacteria that can be found in your gut can translocate its way up to your mouth, and some of the bacteria for periodontal disease, which is, cavities and everything else, how that can play into your neurological health, how your brain function is. We go into so many different concepts that I know for a fact most people don't even have a clue about. And I think you're going to love the podcast because, again, we go into such detail, and he's fantastic. And I think you're going to love him. I think he's going to be, a very good adjunct here and a good, professional here in Cookeville. Obviously, he already has been. He's been established for a while, but I look forward to it. I mean, we talk about amalgam fillings, Mercury, root canals. Like I said, so many different controversial things, his take on that, what that means for you as the public. And then again, we're just looking for more fun. So again, I hope you love this podcast. We're going to jump in real quick. And if you guys have questions, comments about certain things, I know he's already said that he would love to answer them for you. So go ahead and send your comments in. Go ahead and send your questions in. We'll go ahead and go through all of them and get back to you as soon as possible. And we'll likely put them out so other people can see what you're asking as well. But again, welcome to Second Opinion. I'm Dr. Trevor Eason. I hope you love it. So it's going to be good. So before we start, I guess I want the audience, my audience, to know a little bit more about you. Where's your practice? What do you do? What do you offer?
Awesome. Yeah, like you said, my name's Justin, a dentist here in Cookeville, Tennessee, and I'm a solo dentist. Obviously, dentists can be any number of formats, but
of course.
We decided a long time ago that it fit us the best to just have one doctor, so that way patients can have a really good continuity of care.
Yes.
And that's the main thing that we offer is specialized care that really is tailored to the individual.
Yes.
I've got an awesome team, and they do a lot of the work for me as well.
I can attest to that for sure.
We spend a lot of time training ourselves to be on the same page with everything, which I think you were able to see that they're able to handle a lot. So we do try to incorporate the whole body to what we're doing. We're trying to diagnose for the purpose of overall health, not just aesthetics, cosmetics, all the things that are great in dentistry, but trying to treat it for the whole patient.
Absolutely. And I've loved being in your practice. I think it's great. I think you have a fantastic team. And the big part of why I'm having you on today is because we really want to butt the noise of what's true, what's not true. Heavy controversial things like mercury fillings, amalgam fillings, root canals, bacteremia, periodontal disease, what this does for our overall health, all these other factors that, I think you are leading the way. And like I said, I've been involved with that when it comes to setting the precedent, setting the standard within what that looks like in proper dentistry and where we're going with research and everything else. So one of the first questions I want to ask you is, we know that periodontal disease, we know that dental caries, all these factors are problematic, but the question I have is your mouth making you sick? And is there potential that your doctor is missing it and somebody like you can come in and give us some inclusion about that? So is our mouth making us sick?
Yeah, I mean, first of all, there are lots of doctors that do what I do. I'm not the only one, but there are a lot that don't. And we get patients in every day that will be checking for gum disease. That's one of the biggest things that we find that contributes to the whole mouth. Obviously, cavities or dental caries contribute to those. The materials we use contribute to them. But one of the biggest links that the medical side is finding that the dental and the medical come together is the role in gum disease and overall health. The role of certain bacteria that are prevalent in periodontitis, which is advanced gum disease, and its role in other conditions like Alzheimer's. Porphyromonas gingivalis is the bacteria that we're definitely finding. They're finding that bacteria in the brain of Alzheimer's patients. Is it linked where the gum disease is linked to that? We don't know that yet.
Sure.
But it can't hurt to help protect those things. So yes, we find patients that have never been measured for this, and the way we measure is specific, but we're checking for gum disease. And when patients tell us they've never been measured before, they've never been checked for this, and at first they think it's weird, but by the time we're done and we talk through what we're doing, why we're doing it, they really appreciate that we're looking for more than just the teeth.
Oh, of course. And like, I'll be honest with you, like you just gave me this report just a second ago showing like what types of strains you're looking for, how you categorize them. And we know specifically, based in medicine and how we kind of collaborate together is that sense of like, now I know that when I'm ordering a CRP or an ESR or tumor necrosis factor or IL-6, checking inflammatory markers within the patient, I might not just be looking at advanced cardiovascular disease. I may not be looking at autoimmunity. I may be looking at bacteremia from their mouth that most providers aren't even paying attention to.
Yeah.
And like you said before, I think that we don't know specifically if it's caused by that, but there's a deep correlation between the specific bacteria. I'm not even going to try to pronounce that dinosaur name you just said. But within that, when it comes to deposits into the brain, right?
Yeah.
So like we know that that can be, if they're finding it within cadavers or tissue or biopsy and everything else, then we know that that's at least a correlation causing some damage. So we... specifically what I would say in that context too is like you mentioned something about like bacteremia. Now we don't have to go too far down there, but I know specifically that we have certain medications and certain medications that I may give that may be liposomal in the form of sublingual absorption, meaning like if a medication can be absorbed in the mouth into the bloodstream, we also know that bacterial change can be absorbed the same way. And then they can turn into the bacteremia that you're talking about. So I guess give the audience a bit of understanding about that when it comes to how these things may play into cardiovascular disease or different chronic infections or things like that just from the mouth.
Yeah. So the route of administration is a little bit different. When you're giving medications sublingual, whether it's nitroglycerin or whatever, that medication is specifically formulated so that it can penetrate through the tissue under the tongue. That tissue is more permeable, so those medications can pass through. From what we know, bacteria doesn't act the same way per se. The biggest issue we deal with is the teeth are the only bones in the entire body that are exposed to the environment.
Yep.
Every other bone is completely encapsulated. So with teeth, you have this little suction cup of gums that are trying to protect the bone from allowing bacteria to sneak in. And when that bacteria gets a foothold, your body tries to kill off the bacteria.
Sure.
What that does ends up opening up pores, essentially. They're not pores, but opening up those areas where bacteria can now leak into that area. And as that bacteria becomes more and more prevalent, instead of your body fighting off that bacteria gets into the bloodstream and starts coursing through the body. So that's the reason why if any of your audience has had knee replacements or heart valve replacements, they always recommend antibiotics prior to dental procedures because they found that they take out artificial knees and they test, hey, what made this thing fail? Because they want to find that out. And they're finding bacteria that's only found in the mouth. That bacteria couldn't have gotten there any other way. And when you've got patients that have susceptibility to bacteria pouring through and getting through the body, that's one thing that we really want to pay attention to.
Absolutely.
And the healthier we get the gum tissues, when your dentist is talking to you about curing gingivitis, getting rid of gingivitis, getting the inflammation down, getting your numbers down, getting your bleeding points down, all of that is pointing to fixing that suction cup to becoming healthier, to actually preventing bacteria from getting into that space.
Absolutely. And like, it's funny you bring it up too, because I know I get that a lot in what I do, specifically with like intestinal hyperpermeability when it comes to degradation. And like, I guess a landscape that I would say too, is we know that from your mouth to your butt, everything's connected. I mean, that gastrointestinal tract starts at your mouth and goes all the way down. And we know that like, if you're having bacteria in your mouth, that can go into your gut and vice versa. And I've seen plenty of times before where like my daughter, who you saw, who had this specific type of bacteria, we found that same bacteria in her gut. So we don't know what happened, chicken or egg, but that bacteria just destroyed her mouth in a rapid way where, you know, now I have to do things that I don't want to do because I know that, such as caps and everything else. But by your guidance and the referral process with everything else to a pediatric dentist, it was one of those things where like, even if we fix what we did and we preserve the structure of her mouth and everything else, it's one of those things where like we still had to go in there and fix her gut. This happens all the time with my patients when it comes to, you know, tight junctions, gap junctions, specifically in the gut. Same thing, permeable membranes in the gut and the mouth too, where like that stuff can leak out. And like, we can't just move into the old archaic knowledge of like where it's found is where it's going to stay. That doesn't make sense. And you've purported that already. So in that same respect, like we have to take care of the oral microbiome just as much as we have to take care of the gut microbiome.
Now, in your practice, how do you handle those permeability issues? What's your processed from a gut perspective.
For sure. So like what we do specifically has a lot to do with what's going on with the patient. So we order a specific GI testing that has like 95 to 97% sensitivity and specificity, meaning the reliability is there.
Yep.
It's rarely ever wrong. In that same respect, we have to make sure that there's not a pathogenic bacteria. Can't have Campylobacter, can't have Escherichia E. coli, can't have these other factors that are there because we know it's going to increase that inflammatory product. We also know that like if there's dysbiosis, too much bad in comparison to good, you can't just take probiotics and prebiotics. You have to moderate what that looks like because, again, if I give immature probiotics in a pill, one, they're going to be pooped out because the bad bacteria is higher than the good. And specifically,
So they aren't effective when you have too high of levels of the bad
well, it
bacteria.
depends. So like I would say like in certain cases, yes. And what I'm describing here is like small intestinal bacterial overgrowth where that bacteria's got smart enough where now it's translocating its way from the stomach or large intestine to the small intestine. But that's when it becomes like heavy.
Yeah.
And we can monitor that and we can test for those things. But in the same respect, like we know that prebiotic fibers and prebiotics are specifically there to feed the probiotics. But again, like bad bacteria also eats those prebiotic fibers as well.
Yeah.
So like if there's a disproportionate ratio between the two, we have to disseminate and kill that bad bacteria or bring it down so it's an equitable rate or a neutral state between the two. Because if we don't do that, then we can't fix the problem.
Right.
So in the same respect, like it's not just about repopulating the gut. You can't just take probiotics and prebiotics because social media told you so. You do need specific testing to figure that out because, again, at the end of the day, you have to kill things off. And typically we will put people on restrictive diets, not intentionally, but to prevent carbohydrate loads that can feed infection, feed bad bacteria. And the same thing is true. Obviously, we're not going to have, people, sucking down nicotine all the time in their mouth. We're not going to have them, chewing on sugary gum. And I know you've recommended xylitol for those things for dental caries, and that's a beautiful thing too. You can talk about that. But it's one of those things where like we just have to use the tools available to us, and we can't be archaic in that nature. We have to utilize research, and we have to be able to, set the standard.
And be aware when things change.
100%.
Because ours is the same way. Very few dentists do it this way, but when it comes to, like we're talking about periodontal disease, it can be caused by any number of bacteria. Like you said, there's good bacteria and bad bacteria. It's not one that's good and one that's bad, and you're trying to figure out which one to grow. There's multiple bacteria that cause it. So we do a specificity test to see what are your levels of these green, yellow, orange, red, and pink complex bacteria.
Yes.
And one of those is the one we're talking about with Alzheimer's, P. gingivalis, that when patients aren't responding to normal treatments, we'll usually test after that.
Of course.
And in almost every case, if we're doing normal hygiene, debridement, whatever the treatment needs, we follow up with the patient and things aren't healing, that's where we jump to it and say, there's probably a bacteria here that's making you resistant to us being able to heal you.
Correct.
And every case that we've tested has had high levels of those red bacteria. So it's a good test to say, but it requires a different protocol. I can't just clean you and get you healthy because this bacteria will never go away.
Correct.
With normal methods.
And we talked about this before. So like in that case, like we may be using antibiotics, yes?
Yeah.
So tell me a little bit about that.
So it's using antibiotics in conjunction with gum therapy, debridement of the bacteria, but it's a specific modality of the type of bacteria is only susceptible to certain antibiotics. If I give you an antibiotic that's not custom made for that bacteria, it's doing nothing.
Correct.
I get patients in all the time that said, I went to the ER and I had a dental infection and they gave me this antibiotic. And I know what that infection is, and I know the antibiotic that they gave you, and I know that they're doing nothing to help each other.
Now you create another problem.
And in some way, you're actually potentially hurting it because the antibiotic may be killing off the good bacteria, making the one that we're actually trying to fight worse.
Yes.
So we normally partner it with some sort of cleaning mechanism, as well as an antibiotic, as well as some sort of rinse to help continue that cleaning process in between. If that isn't successful, that's where we need to go to surgical therapy, laser therapy, bigger things that go beyond that.
For sure.
But my methodology is always to start at the lowest common denominator. Every single patient doesn't need to be tested. Every single patient doesn't need laser surgery. And that's one of the rough parts of dentistry is that those can be done on everyone, but not everyone needs it. And so it's taking a step-by-step approach of saying, is the simplest solution working for you? And if it is, great. If it's not, let's take the next step. Let's move to something a little bit more thorough to try to capture what's there.
Absolutely. And we talked about this too, where it's just like, and you can kind of attest to this as well, but like with the old school dentistry, moving in and using specific antibiotics like clindamycin and so on, we know that specifically clindamycin over and over again, specifically with long-term dosing or even short-term dosing, has been associated heavily with Pseudomonas colitis. And it's causing, not only C. diff, but just massive destruction. For what reason, we don't necessarily know. And, we talked about the position where you stand on this. And I think, like, we can't continue to stay where we're at. So when we're talking about specifics, and we've talked about before, it's just like anytime I have somebody on antibiotics or for prescribing antibiotics for whatever it may be, I have them on a specific regimen where, like, they're getting probiotics as high into the 30 to 50 billion based on the research that we've looked at and the cohorts we've had on our patients to disseminate the loss of bacteria that's there, because we know antibiotics can destroy the gut. Not can, they do, good and bad. And within that context, we know as well that, like, it takes roughly 6 months to a year to replenish that ecosystem after one antibiotic course. Yep. Not to mention something as devastating as clindamycin. So in the same respect, we have to repopulate that. And it's not just like, you don't take antibiotics during the course. No. You have to take it during the course, and you have to lay it down. And then specifically, we lay down things like, 30 to 50 billion of probiotics 2 to 3 times a day. Yep. Sometimes the 50 billion at 150 billion 3 times a day is too much, so we back it down. But we also use Saccharomyces boulardii because that's a yeasted probiotic that helps keep that damage down, but also make sure that proliferation of that bad bacteria cannot happen past that. And like I said before, we typically say, like, hey, unless we're on a different protocol, you should be taking this for a couple months after or a month after, and depending on what we've done already. Like, if somebody hasn't had any inclusion of that, like, yes, they're going to be on probiotics and everything else. Right. But where do you stand with that? Do you use probiotics when you're doing those things?
So I used to not, but I kind of live by the motto of once you know better, you have to do better. Mm-hmm. And a big continuing education course that I've been a part of, the Coyce Institute, one of the best programs in the world.
Sure.
The director there, he's a big advocate for it. Initially, when I saw it, the first couple courses I went to, he always talked about it. I'm like, oh, that's just an extra thing that I need to stock on my shelves.
For sure.
Because I didn't know any different. Mm-hmm. And the more you learn about how impactful, like you said, a 2 or 3 day course of clindamycin, a pre-med of clindamycin, can throw everything into disarray. Yeah. So I haven't done it in the past, but going forward, that is definitely a specific type of probiotic that's beneficial from that aspect. Is definitely something I subscribe to. Because I think partly we just didn't know how much the long-term downstream effects were of antibiotics. And I can tell you in my world, we write antibiotics all the time. The patient that needs a tooth taken out but is traveling next week, so they don't want it out now. Can I just get an antibiotic to help suppress it? Yeah. And they forget about it until it hurts again. Well, I can't do it now. Can I get another antibiotic because I need to put it off? Or cost can be an issue. Sure. Time can be an issue. Whatever the barrier is, it's easy to just keep writing that prescription and saying, oh, yeah, I understand, Mrs. Smith, I totally get it. Here's your antibiotic and come back later. And once you know what those long-term effects down the road can be, altering the gut biome, you just can't keep going down that road.
Well, yeah, for sure. So it's just like one of those things where everything's connected, and if we start to disseminate that and, push it into these regional areas, we're no better than anybody else. I don't know how many times we'll inter-refer and how many times I get calls from specialists that are just like, hey, man, thank you so much for doing your job and not referring somebody that doesn't need to come to me, right? Just because we look. And we talked about it too. So, like, within dentistry, we know that, like, within the context of, like, finding certain things prior to, like, a PCP find them, you're a point-of-care provider, physician in that sense, and we can definitely figure out, like, things. And you've talked about a specific case with a staff member that, like, is pretty powerful. So tell that story for the audience.
Yeah, the biggest thing that we've found, and part of the reason why I've moved our model to checking more than just the teeth, every one of my hygienists or the providers that see the patients every 6 months, I'll pop in as well. Sure. But they're with the patient for the hour. Yep. I'm in there for 5 minutes or so, or usually less, just saying hello, finding quick information about them, and sometimes making more decisions. But they're with them for that full hour. And it was about a year ago, my hygienist was doing a normal oral cancer exam, head and neck exam of a member of my team, and started to feel a little lump in the neck and said, hey, have you noticed anything here? And she said, yeah, it kind of feels swollen, but I'm not really sure what that is, and started feeling around and saying, hey, there's something wrong. here. So went through referrals. Long story short, she had thyroid cancer.
It's insane.
So I had to have her thyroid removed, and had her hygienist not found that, I don't know that she'd be here
Exactly.
long term. And so obviously negative effects of having your thyroid removed, which apparently the thyroid's important.
It's pretty darn
that.
important, man.
Yeah.
I know it's so important.
But yes, the model of most people only see their doctor if they're feeling ill, where our model is seeing you every 6 months. So we take blood pressure on every patient that comes in.
Yep.
Some patients hate it. Like, why are you taking that again? My blood pressure's fine. I can't tell the number of people that I've had come in my office and have a blood pressure of 200 over 160 and had no idea blood pressure was an issue.
Yeah. I'm about to die.
Funny quote from my hygienist, actually the same one that found thyroid cancer. She said, if you were my dad, I'd be driving you to the hospital right now. And she is able to communicate with the patients and instill that urgency because she cares.
Of course.
She cares about that patient. I'm not sure if you did or not. I haven't heard back yet. But it's that kind of stuff that dentistry has a different model that we're seeing you on routine schedules for a reason. I need to see you on routine schedules to keep your mouth healthy. But if I'm already seeing you every 3, 4, 6 months, depending on what your protocol is, why not check the big stuff and try to get a little glimpse into some of those issues?
Well, yeah, and I guess the biggest thing that we're trying to show here is just dentistry is important. And I think a lot of people will push it by the wayside simply because maybe their insurance doesn't cover it or something like that. And I've already talked to you about where I'm at with things. Like, I don't care how much it costs.
Yep.
And I'll give you a little tidbit story where, like, you know, I had a gingival disease and I had been told forever that I had gingivitis, and I still was doing the right things. Come to find out, like, my gut was messed up and I had to fix that too. But in the same respect, it was one of those things where, like, I come to your office and it's just like, yeah, I can already tell you, I think I probably have periodontal disease because I feel like I have recessed gums and, like, these things are getting a little worse. And I don't really know, like, what else to do, you know? And, you know, your team came beside me and basically said, like, you know, like, I don't think it's happening. But then they went and checked and did all those points, naming off all those numbers. And, like, I have no idea what it means. I get it now. But it's one of those things where if I didn't hear from you and her that debridement was something that was necessary to remove potential colonization of bacteria, plaque, these things that were right up against my gum line, causing inflammation on the regular basis, versus just another provider or a dentist saying, like, you just need, or a hygienist saying, you need to floss more, just brush more, make sure you do that. I heard that for years, and nothing changed until that happened. And my point in saying all that is sometimes in medicine, and I've been pushed in this, where I'm afraid to tell somebody a care plan that is expensive. Simply because of the fact that, like, I need them to trial something, and I'm always fearful that the price tag is going to be much. In that moment, when I'm in your office sitting there, it's just like, I don't care how much it costs. I want to know what's going to fix this for the good, and I'm willing to pay what it is because my health means more to me now than a few extra $100 or whatever it may be.
Yep.
Because at the end of the day, like, health's something you can't get back. Money's something you can. You can make more any day. And I think, like, the point is, like, I was appreciative that your team and your staff was just like, listen, this is the option. And you can either continue doing what you're doing or you can do the debridement and we can see better outcomes and we'll check and see. We did it, came back. My numbers were better. I got different toothpaste. I got different things. Everything worked. Yep. And your team did that for me and I was appreciative of it. So in the same respect, I guess we can jump into the next question. So, like, big one, Mercury fillings.
Yeah.
Fun stuff, right? So we talked a little bit about this. Where's your standpoint in that? What do you know about it? Why is there such controversy within the realm? And yeah, it's a big point of contest, so let's talk about it.
It's one of them. There's three that seem to always make their way around the social medias, and
this is true.
Every couple of years they reset, and I see them again. So for those of you that don't know, Mercury fillings, the name of them are amalgam fillings. Amalgam is the name of amalgamation to combine a bunch of things together. So the old way of doing it, because that's all they had at the time, was to amalgamate many different minerals components into one to create a restorative material. Copper, mercury, tin, all the things that were put into that. Over the years, the formulation changed, but mercury has been the binder that actually helps all of that material settle. The mercury is what actually had those materials fused together. So yeah, lots of controversy with it because elemental mercury is not free once it amalgamates together. However, there is research that in certain conditions, when that amalgam starts to corrode, when it starts to break down, or the biggest factor when that mercury vapor is released is on removal of that amalgam. So that's one big topic is how much is that affecting it.
For sure.
So before meeting you, I didn't. I knew a lot about it.
Sure.
But obviously, you're very intentional about catching the small things that I think for so often medicine ignores the small things and waits until it becomes the bigger thing. And I think a huge aspect of preventative health, let's catch those small things before they start snowballing, before they create bigger issues. So where do I stand on it? Silver fillings, I don't place them. I always joke, I place 2 a year. It seems to always happen. There's 2 a year. There's certain situations, maybe on a geriatric patient that we're just trying to buy some time. And the new white fillings, resin restorations, composite restorations, they need to stay completely dry when being placed. And if you're working on a 95-year-old patient who can't open up very wide, hypersalivation everywhere, and there's a spot that you just got to get something in there, that's cost to risk analysis. Or in some cases, underneath an old gold crown, we don't need to replace the whole crown. We'll just kind of put it in there, seal that area off. So certain instances, but my team always joke that he places 2 a year. So he already placed the second one. He's done for the year.
For sure.
So small cases where it's needed. For patients that come to me, I don't place them anymore except for the 2 a year. For patients that come to me, there's certain factors that tell me a silver restoration needs to be replaced. One is if it's actively cracking, breaking down. If it's cracking and breaking down, the chances of you swallowing that restorative material are high, and that's what you're testing in the gut is where is this mercury coming from? Where are these small particles coming from? So digestion of the actual material doesn't happen often, but that's one thing we're looking for. The biggest thing that I look for is corrosion around that restoration. The tooth will actually discolor, turn a bluish, grayish hue. It's a sign that moisture is actually getting between the filling and the tooth. That moisture is sitting in that position, creating a chemical reaction where that restorative material is corroding and actually staining that whole tooth. So I'm not testing for that corrosion, but the tooth will start to show signs that it's breaking down. Those are the two biggest reasons to replace them. The other big factor as to why silver fillings aren't fantastic is they don't actually chemically bond to the tooth. So new white restorations form a chemical bond that actually links the restoration with the tooth together. An actual covalent ionic bond, I can't remember exactly which one it is from dental school a couple of years ago, but an actual chemical bond. And so moisture doesn't actually get between the tooth and the filling. Once that adhesive starts to break down, we can actually see that breakdown. It'll start to discolor at that margin. That's a sign that white restoration is failing. Between a silver filling and a tooth, there's no chemical bond. So moisture from the day that filling is put in is getting down around that filling and just sitting there. And so because there's no bond, that moisture is always in the area. But it's not until that moisture starts to become more prevalent that material starts to corrode, break down. That's a sign the material, in some cases, is actually debonding from itself. And I think that's where some of that mercury toxicity can come from, is that slow leak as that material is corroding.
Absolutely. Hey, Dr. Brock, will you look up the statistics of how many people or how many times in the U.S. people are getting amalgam fillings still in 2025?
That's a great question.
It's a fantastic question for the audience to know. We can jump in, but the big thing is just like in the context is we've talked about this, and like when I'm because it's funny too, because I didn't know that was the discoloration pattern. I have people open their mouth all the time. You do see it in the elderly where that's happening, and now I'm like, oh my gosh, like I'm just like light bulb right now. And I'm like, holy crap, I've seen that. So like in that same respect, now I know specifically because, and this is why you should always pair with your dentist, your pharmacist, everything else to make sure that everybody's on the same page. Because in today's age, nobody knows what's going on. You got like 15 different providers. Nobody's cross communicating and everything else. But this is important. It's important for what I do, and it's helpful to have you in that spot to say like, hey, like, you know, Trevor, you should definitely check this out because we're seeing this discoloration, like do a heavy metal test to see. And like, what do you know? We do a heavy metal test and their mercury fillings are causing them to swallow mercury all the time. And now they're heavily, you know, inflammation cascades are through the roof and blah, blah, blah. And now we have to chelate and whatever. And it makes it harder when they're older because chelation is extremely difficult on the kidneys. And we know that your GFR is already going down at that point. So there's time than that cascade, but it's a beautiful adjunct to have. And we know that mercury is a big issue. And I would even say, like, I get it all the time where like lead, mercury, cadmium, all these other factors that are just like in the test all the time. So it's just like, where are they coming from? And if they're not doing shellfish and sea fish and swordfish and shark and everything else all the time, where's the mercury coming from?
Yeah.
Albacore tuna, maybe? I don't know. But it's one of those things where we definitively want to make sure, like, if they have amalgam fillings and we can define it, like, those need to be removed and there needs to be a specific process. I know a little bit about it. I know you're kind of like studying into it now. Did you find anything? What do you got for us?
So pretty minimal, but it is showing that the droppage is down to 4% as of 2023 in overall filling usage.
That's good. And like you were saying, like, am I saying the right ceramics?
Resin composites.
Resin composites. So like basically we know, and like we've talked about before, that like anecdotally and through research, these are way better counterparts.
Yep.
And they just last longer and they're better. Where before I think you were talking about, you know, they may have to replace them every 5 to 10 years or whatever it may be. And nobody wants to do that. Like,
well, and they're also much more technique sensitive. I saw a big issue in that shift from silver restorations to white restorations where some dentists didn't really make that transition well. Because with, like I said before, silver doesn't have to stay dry.
Yeah.
So if you're putting that restoration in, you can pack it in with your thumb, shape it up a little bit, tell them not to bite on it for a couple hours, and they'll be fine.
Of course.
If you don't keep those resin restorations completely dry during the process, that chemical bond can't form. Any amount of moisture in there is going to compromise that, whether that's bleeding in the area, saliva, air that's caught in your air water lines. Any amount of moisture can compromise that bond.
Yeah.
So then you go from a restoration that I think should last 15 to 20 years.
Yeah.
To all of a sudden in 5 years, you start seeing, hey, it's kind of breaking down a little bit. This is starting to have issues. What happened? And there's no way to know. Was it moisture? Was it whatever? But I saw a big issue of dentists trying to make that transition, trying to place a white restoration with the same techniques of the silver, and they're completely different.
It's good to know. So training's important.
Training's important.
Yeah.
But that's why with insurance companies, many insurance companies will downgrade a white restoration to a silver restoration. Why is a silver restoration cheaper? It's not the material. I mean, the material is cheaper to use.
Sure.
But the bigger thing is white restorations are more technique sensitive. They're harder to put in.
Gotcha.
So that sometimes plays into the difference in cost between silver fillings and white fillings.
Well, yeah, you know, you want your dentist or your provider to be pretty proficient at what they're doing, and if they have a higher skill set to place them, then obviously that's better for you as a patient.
If we're at 4% nationwide, it's kind of a non-factor now. It sounds like people have moved past it. I still see a bunch, but silver filling. I mean, I just took one out last week. He said, these were placed when I was 8 or 9 years old, 60 years ago.
Yeah.
So these things can be in the mouth forever. And there was some mess underneath it. There's no question. There were some issues going on underneath it.
Yeah.
So they can last forever. So even though nationwide we as a dental community aren't placing them as much anymore, there's still millions of fillings out there.
Oh, correct. I mean, like I get it all the time where I'm like referring out to, you know, to have them taken out and everything else. And we prefer certain techniques to make sure they're not just spilling everywhere. Because like you said, like that's where that problem's coming from. And even then, like if we suspect it, and I look in their mouth and it's just like full of metal, then I'm going to chelate. I'm going to do the test. And once the test comes back, it's like, yep, it's positive. Okay, go meet with your dentist, go meet with whoever, and get this taken out and make sure that like this, and this is in place. And then they come back to us and then we chelate, making sure that their tissue's good, kidney function is good, all the way about it. But once that's done, it's done. Yep. And that inflammation cascade goes down, and now they have the composite, now they have whatever they need. So it's just like, it's one of those things that it's obviously a big topic for discussion. People are concerned. And I think we talked about too, we don't know like within the elemental mercury versus like ethyl mercury, but we do know specifically within mercury that was found in water and those things. It's like, we know I think it's 1 microgram equals parts per billion of the ethyl mercury. In the same respect, 2 parts is going to cause some issues. 20 parts is going to cause neuronal damage. We're having some neurological dysfunction. And then lastly, the EPA has already categorized 200 parts per billion is hazardous waste, right? So in that context, we can't clearly say like what's the, you know, chemistry set of this versus this, but we do know the mercury has some significant problems to the human body. Yeah,
and right? the same issue back when dentists were placing silver fillings the most. Anyone my age or older grew up with a spit bucket.
Yep.
You had a little bowl next to you that there wasn't any high volume suction.
Yeah.
They drill it out. They used slower speed drills with less water.
For sure.
And all of those things increase the amount of mercury vapor that's released when a silver filling is being replaced.
Yeah.
So the worst things you can do is work in a dry environment. So taking it out while it's dry creates much more moisture vapor. Not using suction, so having that spittoon that you're spitting into in between procedures. And then not taking it out in chunks. So that's one of the best things you can do is actually just kind of work around the filling and let the whole thing come out and suction that away versus polishing the entire thing away until it's gone. So you're decreasing all of those things. So yeah, at our office, we have a good protocol of high volume suction, which pulls those vapors away. If we're really concerned as far as the amount of that, we'll use a rubber dam, which isolates that area so the patient can't breathe it in through their mouth. We'll also put them on oxygen, so that way they're breathing oxygen through a tube. So that way any mercury vapors that are being created, they're breathing from supplemental oxygen somewhere else. So all little steps that you can do, depending on what the patient needs. Obviously, they have mercury toxicity, high or sensitivities to heavy metals. We do that more often, even if it's a small filling. Just because the amount of mercury vapor that's released is completely proportional to the size of that filling, where it is, how hard it is to get to, that kind of stuff. But
absolutely,
there are things that we can do in modern dentistry that dentists 30, 40, 50 years ago just weren't doing.
Correct. And I think that's just a progressional change in like what you're bringing to the public here. And it just goes to show like what you're paying for is an outcome. You're paying for expertise in medicine, expertise in dentistry. You're paying for certain things because the safety, the education, the experience is what makes the process good or great in that same respect. So next topic, fun one, crowns or root canals. So
root canals.
Root canals are fun, man. We know, and specifically, I'm going to catch flack on this all the time, but we know that dentists, at least you can help me out on this, that are the only medical profession that leaves dead tissue in the body. Is that a true statement?
It's debatable. So I would love to know from a medical perspective, are there other areas where kind of we're leaving dead things behind?
I mean, we leave scalpels inside people, so
those never turn out well.
For sure.
So the process of a root canal. The analogy I use a lot of analogies in my daily practice, but I think it helps patients understand what we're seeing. I can use big dental words all I want, but unless I dumb it down, don't mean that. But put it in a way that people can understand.
Of course.
It's meaningless. It's just me using big words to sound smart.
Correct.
But the way I use an analogy for root canal is think of a Twinkie. So basically with a Twinkie, we just kind of punch a little hole in it. We take the cream filling out, and then we restore it with a rubber material called gutta percha, but seals that back up. In the process, we're using heavy disinfectants. That space where the cream filling was, any amount of bacteria, dead tissue, things that can't stay behind, we're using chemicals to disinfect, clean, and make sure that what's in there is as sterile an environment as possible. We can't fully sterilize because we're not introducing heat to levels that would fully sterilize, but
for sure,
sanitizing to a level that is able to reduce the bacterial load. Once we're done, sealing at the very end. So before we started, the body creates nerves that go in through the roots of the tooth. When bacteria gets to the nerve for other reasons and the nerve starts to die, that channel is still open. And so after we remove all that bacteria, remove the cream filling, we seal the very end. So now we've sealed off where the nerve was, where the cream filling was, and the rest of the body. And when done well, and it's called the apical seal. When that seal is done well, is it dead tissue? I mean, it's still a bone. The tooth is still in the bone. And that suction cup I was talking about before, of the gums holding that in place, that goes all the way down. There are fibers where the bone and the tissue attached to that tooth.
Sure.
Even after root canal, those fibers don't go away. The body is still connecting to this tooth in that area. You can still feel proprioceptively pressure on that tooth. If I root canal treated every tooth in your mouth and you were to bite down, you can still feel that pressure because the body is still attached to it.
Sure.
So a lot of the controversy does come back to research from the 1920s. There was a research article which has been debunked, or which, all research I think can be valid.
Sure.
But I don't know how many people are getting their medical advice from the 1920s anymore.
For sure.
Unless, maybe you're still into leaching and bloodletting and all the things that came back then.
I'm here for it.
So no, came back then, but at the time, they weren't disinfecting the same way that myself or root canal specialists are disinfecting now.
Correct.
They weren't sealing that apex as well as they are now. In general, they were putting a silver point into the tooth. That was one methodology. Silver is antimicrobial, helps to decrease the propagation of that bacteria, but doesn't actually kill it.
Yes.
So it's sitting there forever and always. It's keeping the levels down.
Yep.
But as I'm sure you're aware, Just keeping levels down isn't sufficient for everybody.
Yes.
So we do a lot of steps to make sure that all of that bacteria is gone, the infection's gone. And one thing that we do that most dentists should do, I don't know other ones, but we will track. I know my specialist will track 6 months afterwards, and they'll take an image of that tooth, a 3-dimensional image, same thing I do, to track, is that infection getting smaller? We can track the inflammation at the end of the tooth.
Yeah.
And if we see that inflammation getting smaller, we know that the body's healing it, it's containing it. And it usually takes 2 to 3 years for that inflammation visibly, radiographically, to disappear. But as long as we see it continually getting smaller, it'll get to the point where you can't see it visibly, and it'll stay in that point. But we continue to monitor it year after year after year. Or if we see that inflammation start to come back, we'd either retreat it or possibly take the tooth out then.
Sure.
But we're tracking for signs of inflammation. We're tracking to make sure that the body is healed this tooth and is still incorporating it without any signs of recurrent infection of these dead teeth that are causing these general health issues.
Great. So in that same respect, help the audience member know, like, because a lot of people will say, like, well, why don't you just take the tooth versus placing a crown? So with the root canal, like, when would each of those situations be best?
Absolutely. So everything is a risk assessment. Every single situation we look at. There are many cases where I look at a tooth where the infection is so big and so profuse, there's so little bone remaining around the tooth that I wouldn't recommend root canals, and would say, hey, you're better off taking this tooth out. We have to actually pull this infection out of the area. Yeah. Anytime a tooth has a big fracture, it actually shows up differently radiographically. We can see a fracture.
No. You said what tooth?
Infected.
Okay,
I don't remember.
Okay.
Infected tooth.
Yeah, good.
You're asking questions I can't answer. So when there's a fracture, there's a specific test visibly and also probing around the tooth that we can do that we can detect that fracture.
Yep.
Once that fracture forms, it's not a good idea to root canal treat that tooth because that fracture is causing issues, and that's where it needs to come out. But ultimately, what we do when a tooth needs a root canal, right? I hesitate to ever use the word need, because in dentistry, we always have 5 different paths we could take.
Sure.
There's often not one. This is the only thing that you can do. If we need to do the cheapest option, we can do this. If we want to do the best option, we can do this. There's always multiple things that we can do.
Of course.
But in a tooth that requires something, say patient doesn't want to do a root canal, what are our options? We can take the tooth out, and we can leave that space empty. The tissue will heal over that. There will just be a gap in that area. We can do that. What are the downfalls of that? All the teeth will act like dominoes in a way, that if you're pulling one out, that tooth is holding the other areas up, and so the teeth next to it can fall into that space.
Got it.
The teeth on the opposite arch will actually continue to grow. Teeth will continue to grow until they meet their partner, and that oftentimes stays your entire life. So if you remove a tooth that's holding that top tooth in place, it'll start to try to find its partner down in that area.
Okay.
So now that tooth has grown to a position where it's out of the way. Now your bite won't come together right because that tooth has come into a negative position, oftentimes leading to the loss of this other tooth.
Yep.
It happens all the time where the bite collapses, the tooth falls into that space. We have to take it out. So say we don't want to leave that space empty, we can put something else in there. We've got removable dentures. I have yet to have a patient that's like, Doc, I love my removable denture. It's my favorite thing. I love taking it out. I love cleaning it. They're fine. They can work, but they're no one's favorite. We can do a bridge, which is essentially 3 crowns that are all fused together and glued to the 2 teeth next to it. Downfall of that is I have to remove, and oftentimes, good tooth structure on the 2 teeth next to it. We're damaging good tooth structure that didn't have to be lost. So that's a big con of that. Our bridge is awesome. Can they last a long time? Are they a staple in what I do every day? Sure. Absolutely, but there are cons to it. And the last big option is a dental implant, which I love dental implants. They are fantastic. It's they've really come on to the market well over the last 20 years. They've been around since, I actually just saw a picture of the first ever dental implant. Maybe that's a good question for you, Brock. When was the first dental implant, Dr. Brock? When was the first dental implant placed?
That's a good one.
I saw a picture of it.
It was wood?
No, not George Washington's teeth, but yes, I mean, they've been around, my guess is 70 years, but they are awesome replacements in most cases. However, you need adequate bone to put in that area, both width and height. You need to stay away from vital structures. If it's on the lower, when we're placing a dental implant, we have to stay away from the inferior alveolar nerve.
Yeah.
And you need to stay 2 millimeters away, because if you try to put that implant too close to the nerve, you can cause permanent paresthesia to the lip and all those features in there. There's a groove on the tongue side of that bone that if you penetrate through that, you can hit the lingual artery and cause a negative
effects,
contraindication of death.
Yeah.
So things that you don't want to. You got that answer?
The first modern dental implant was placed in 1965. Prior to that, you had Mayan civilizations using stones and seashells.
Stones and seashells.
Seashells, baby.
I haven't looked into those too well. So 1965.
Hey, you know.
Because I thought I remembered reading an article. I think the patient that got the first dental implant had just passed away or something that was still in there.
Sure.
So still going strong.
There you go.
But implants can be expensive. They definitely are. There's no way around it. The material is expensive. The surgery is expensive. Now, we have an awesome system for placing implants. It's one of my favorite procedures to do.
Yeah.
Because most patients think about, I'm putting a screw in my mouth. That sounds terrible.
Yep.
And I love the feeling of doing a dental implant. It usually takes, in most cases, when we're doing it guided like we do it, it's usually a 10 to 15 minute procedure.
That's fast.
And I need to numb less than taking the tooth out. So it's a
Really?
minimal amount of numbing, super quick procedure. We get done, and the majority of patients are like that.
That's
That was it.
crazy.
That was all we did. So it's a super great procedure, but
Yeah.
dental implants have their downfalls.
Yep.
The same way we're talking about gum disease that can destroy a tooth. Obviously, an implant can't get a cavity. There's no tooth structure to get a cavity. But that same porphyromonas gingivalis we were talking about can cause a condition called peri-implantitis or peri-implant mucositis, which is essentially gingivitis for the implant. Because that attachment, that suction cup that goes around the implant is still just a suction cup.
Sure.
Bacteria can still get into that. And there's actually the fibers that attach to the tooth are different than the fibers that attach to the implant. So implants are actually more susceptible to gum disease than the natural tooth is. So implants are very successful, high success rate, but they still come with themselves
Sure.
negatives potentially. So going back to the very beginning, is root canal best? Is it the best solution for everybody? No, but it still needs to be part of our armamentarium if it's done well.
Correct. And that's like the big thing. So like, not to cut you off, but like in that same respect, obviously there's heavy amounts of thought that goes into something like this.
Absolutely.
Because most people don't think that. Most people think like, oh, I'm just going to, they just want to do a root canal. They just want to put this, they just want to do that. They just want whatever it may be. But there's heavy amounts of thought that goes into it. I'm sure 99% of people, including me, did not know what you just said.
Yeah.
So that's a good point to make, obviously, because like it's not just like, yeah, we're just going to throw this root canal because it's whatever. There's specific cases, and each of those cases take specific individualized care.
And that's something that's missing in medical, dental, everything.
Everything.
The corporate model kind of takes the person out of the situation, and they forget there's a person behind that patient.
Of course.
And that's what we strive for every day is to treat each individual patient for what's best for them. And in some cases, I have to do what's not the best.
Sure.
For cost reasons or time reasons or whatever.
Yeah.
And I can meet you where you need to be, but ultimately, I hope providers are able to continue to offer that personalized care for each
Absolutely.
individual person.
Well, the funny thing too is my neuro brain just went crazy. So like when you were talking about feeling the proprioceptive stuff in the tooth, we also know, like, is it truly that nerve being blood flow, like giving blood flow, or is it something where it's like a, what is that called? What's that called, Brock? The phantom pain. Why don't I think about that? So like we've lost our arm, but we can definitely feel like there's something pinching my middle fingernail. Is there any
the difference
potential?
is that dental implants, you can't have that same proprioception because the fibers that attach to it are different. So it's an actual bone titanium connection. So the bone is actually integrating into the implant and locking in place. It's a different sensation to the way the periodontal ligament fibers attach to the tooth. So when I have patients that we've removed all their teeth, and we have implants in there and a denture is attached to the implants, they're in the bone the same way a tooth is. But when they bite on that denture, they'll all say it feels different. Something feels off, and that's because it does. When you bite into a tooth, the tooth will naturally compress where an implant will not. So that creates one of the difficulties in dentistry. We don't need to go into those details, but getting an implant tooth next to a natural tooth, when I'm checking your bite, those two teeth will compress differently. So if I have you squeeze, that natural tooth will compress up to 0.2 millimeters in a normal situation.
Sure.
The implant compresses none. So when you bite down, you're going to show that you're hitting higher here just because that tooth is moving out of the way. So when we're balancing occlusion or how the teeth come together in an implant and a natural tooth position, they're different. But that, I think, goes to your question of when they're tapping on an implant, they'll say something feels different. And that's because there isn't that proprioception in an implant that you do have in a tooth. Now, you still have the vibrations in the bone, so there still is some of that. You know the tooth was there, and you can kind of still feel that. But when that implant is in and the tooth is out, everyone will say, like, yeah, it feels weird. It's a different sensation. It feels fine, but it feels different than my natural tooth did.
All around.
Yeah.
That's fascinating. That's crazy. I had no idea. Good points. Is it fair to say that there is still even a minute potential, even if that potential, because we also know, like, obviously there's plenty of times where, like, 85% of the time, getting an infection out, reducing the damage that's nerve root damage and everything else from a root canal is way more beneficial to remove that bacteria and everything else versus just keeping it in there or something like that. That's fair to say.
Yeah.
In that same context, can we say that even if everything goes to perfect standard and everything else, is there a potential that like a root canal can still cause damage? Can we still have swallowing certain things? There's a potential even if we've cleaned it out perfectly and everything else.
Absolutely. There's always that potential. And I'm also open to the same way that we don't know for sure is P. gingivalis being found in the brain of Alzheimer's patients. Was that causative? If we find out that 100% it's from the oral bacteria that's causing Alzheimer's, we're going to not necessarily do anything different, but we're going to put a heavy focus on getting that bacteria gone because that's the source of it. If we find that bacteria from root canals is causing some sort of metabolic issue, I'm totally fine changing that perspective.
Well, it's not only that. I mean, it has everything to do with like the gut-brain dynamics too. So it's not just oral microbiome; it's gut microbiome as well. Because we do know that when we have hyperintestinal permeability, and some of that bad bacteria can translocate its way up to the blood-brain barrier, and now we're having translocation there. It's not like you're gonna feel it in your brain. No. You're gonna have this huge immunomodulation side effect of, like, maybe I'm more anxious, maybe I'm more hyper, maybe I'm more depressed, maybe I have more OCD.
Something's going on,
yeah. And like, it's just like these simple things that aren't, and this is the same thing with the concussion. Like, it's not like chemical concussions are real. Like, if you can hit your head one time and now the blood-brain barrier is broken up, now you have this immunological cascade of like macrophages coming into where microglia or microglia cells are supposed to be like fine-tuning things. They're messing everything up. So you're creating all this extra damage. But the whole point is just this. We know that, like, at least it's a contention for studying this stuff at a greater level.
Absolutely.
Specific to the oral microbiome and the gut microbiome and its effects on brain function, cardiac function, everything else. I mean,
in its current state, our best way of doing it, like I said, is tracking radiographically. Is that infection getting smaller? Is it getting bigger? If it's bigger, what was done is not containing the infection. And either it needs to be retreated or taken out.
Correct. And that for me is just like, if I need a root canal, like, I'm coming to you because you're doing that extra due diligence. And that's what needs to be explained to the patient, because I know my patients will come in and like they're very fearful of getting a root canal. Almost all of them. They know more about it than I do. And I'm like, what?
Well, for good reason.
I
mean, how many times have you heard in your life on a TV, whatever, I'd rather do X than get a root canal. It's worse than a root canal. It's the gold standard for pain. Terrible, awful.
For sure.
And that's one of the things I had to deal with early was patients' concern mostly about the pain. This was in a phase where the dangers of it weren't as big. It was more of, I've heard root canals are awful. Root canals should never be awful. Unless you need a root canal on the day that there's a small window where the nerve is in a hyperemic state. The nerve is basically dying. And there's a small window. It's usually a week or two. That's when they usually come to me.
For sure.
Is in that moment of, this is intensely painful, I can't do anything. That nerve is so hyperemic. There's so much blood in that area where the body's in that last ditch effort to try to kill off the bacteria. But the nerve is dying. Those teeth don't go to sleep. There's so much blood flow that as we anesthetize, the dental anesthetics we use are just washed away. And the tooth doesn't go to sleep. So those are the ones that are painful. But if patients ever in that position, in most cases, we'll say, hey, here's some antibiotics, here's some stuff to help decrease that infection. Let's treat this once you're feeling better. Pain-free process.
But. Absolutely. Well, good. Next point that I want to bring up that most people want to know about, which is a hot topic in politics right now, is fluoride. Fluoride. Dr. Brock, can you look up the current state of fluoride? Because I know that RFK and some of the administration now with HHS is trying to remove that even from the water system. I don't know if that
there are certain states that have started actively removing it.
Perfect.
It is not federal or nationwide. But no, there's some areas that have started the removal process.
So what's your take on that? I mean, like my take is just like I'm all about it when it comes to like using it in toothpaste, making sure you're not swallowing it. We know about the water source and everything else. It's usually about 0.7 ppm that has been categorized as, I think, safe. Correct me on that. We can look that up too.
Look that up too. I think it's in the 0.2 realm, but
yeah, that might be true.
Whatever whoever's in charge of the federal
dyslexic,
levels.
So I'm not dyslexic. What do you got for us?
No, are you good?
So the current standard is the EPA's a legally enforceable maximum contaminant level for public water systems of 4.0 milligrams per liter. And then there's a non-enforceable secondary standard of 2.0 milligrams per liter to prevent cosmetic issues.
And I think that equates, I can't remember the equate, but I think it is like parts per billion. So it'd be like closer to that too.
I learned the parts per million back a while ago in dental school. But yeah, so where do I stand on fluoride? It is a valuable tool. There's no question.
Yep.
The problem comes in toxicity levels. And the problem comes in administration to both the served community and the underserved community. So the initial city, I think it was Grand Rapids, Michigan, somewhere in Michigan, was the first city to do it, and they saw a marked decrease in dental issues, cavities, caries specifically, in that community where fluoride was in the drinking water. And over time, they tested it to see where the safe levels, what's an adequate level. And so there's no question. I can, in most cases, look at kids, adults, whatever. I can take one look at your x-rays. And in many cases, have a good idea of whether you grew up on well water, which is typically not fluoridated, or city water, which traditionally is. There's no question. There's less cavities. The cavities are smaller. They grow differently in a better way in fluoridated water. Now the risk comes. What's the risk of ingesting fluoride? And the ultimate answer is we don't know. We know that in high levels, it absolutely causes issues to the organs. It can cause permanent damage to the teeth. The teeth have an odd appearance to them. Oddly enough, even though they look different, they're less susceptible to cavities because they're so fluoridated that they really don't get cavities if they're so fluorosed that way. But that's what's hard, right? So if a patient comes to you and says, I'm hurting, and you put them on Motrin, okay, 600 milligrams every 6 hours. That's the doses they need. Well, how do you do that in their water supply? So say you wanted to add Motrin to their water supply. Well, how many glasses of water do you drink? So you're trying to do all those calculations.
It's the same thing that we found with the Mercury. Same thing.
How do you dose that? So the same thing with fluoride, where there's a level where it's too much. But there's also a level where it's completely safe, but it's still having effects. That's what we're always looking for in medicine, is where's that state where the material, the antibiotic, the drug that we're giving you is effective, but we haven't yet hit that level where it's toxic or lethal or whatever we're trying to avoid. So fluoride is the same way. If I could have my change, I would take it out of the water. I wouldn't have people ingesting it, but every single kid from 0 to 18 and even into adults would have a toothpaste in their bathroom as soon as they're able to spit out. We can talk about that in a second. Where they're not ingesting any of it, they're brushing it on topically and spitting it out. How many kids go to school without a lunch? Didn't have dinner the day before. We got school programs because kids go home and they don't eat the entire time. We got whole programs to try to give kids food. They don't have support systems at home that are giving them food, let alone brushing their teeth, flossing their teeth, giving them good, nutritious food that isn't as cavity prone. So how do we serve those who don't have effective home structures and not toxify the people that do? So if I had my ultimate decision, that would be it. If I can control all those factors, you can't. So is fluoridation in the water safe? I mean, there's just an article that came out November 19th, I think, that said actually low levels of fluoride are not negatively impacting the cognition of young adults. I think is what it was focusing on. And they actually found slightly different results, that the kids with fluoridated water actually did better on test scores than the kids that weren't fluoridated. Now, you're not controlling for all the factors there, right? Kids on fluoridated water typically grow up in cities. Are the schools in cities more effective than the schools in the rural areas? Is that what plays in this difference? I don't know that answer. But ultimately, it's unknown is the answer. But it's for sure a safe material if used in the proper protocols. Not ingested, spat out, and gone from there.
Yeah, exactly. So I think in that same reference, like we do know that by research, it does reduce up to 26 to 44% or so of dental caries and dental cavities, at least from the research that I saw. You can double check that one, Dr. Brock. Fluoride use, specifically in toothpaste, reducing 25 to 45% of dental caries or cavities. And then specifically, we also know, like, in the big thing, it's just like everybody understands, well, not everybody, but to the lay person of the audience, we do know, and like some of the speculation around fluoride has been everything to do with neuronal tissue, developmental, certain things, moving up to the blood-brain barrier, passing that, causing changes in kids, because we know we use fluoride in kids.
Yep.
In that same respect, is it a compensatory action that cause some of these neurological delays? Is it not? Are we keeping it under that? How much water do you have to ingest? It is an impossible feat to track all of it. And I think like the 0.7 was more closely aligned with like you need to drastically keep it under that level from the CDC.
This is the max that we need to be able to get to, because we know that when we start going over that, we could have neurological issues.
And you can definitely have that. So like you said before, I have not come across like rich systematic reviews, rich cohorts, RCTs and so on that is purporting heavily that like these things definitively at this safe level, according to whatever EPA, blah, 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 that these things are causing the neurological demise that are correlating with it. And if those things come, then yes, we get on board and we do whatever we can. But it is something to play in contention with, because it's a hot topic, right?
And it also doesn't hurt or doesn't help that apparently it was initially brought into circulation because it was a byproduct of some industrial waste, and it was sold as that. Obviously not helpful, for sure, to make it seem good. But there's no question it has benefits in the teeth. And I think a lot of research needs to be done to say at what levels is it safe.
Yeah.
And if the level to make fluoride effective is higher than the level to make it safe, we're cutting it out completely.
Sure.
But right now, I think there is a level where getting that up. But it's hard when it's in your drinking water. How much fluoride does a kid get if he has 10 glasses of water versus the kid that is drinking bottled water every day? You know, what's the level that they're just getting?
Well, for sure. And we already talked about like Dasani being more acidic and what that does to the teeth. Can you look that one up, Dr. Brock? This specifically, because we talked before and we decided that like Dasani typically is a little bit more acidic, which is
but why? Look at the ingredients.
Yeah. I have no idea.
Yeah, I'll take a look real quick just to touch base. You asked about the percentage.
Yeah.
Consistent daily brushing with the fluoride toothpaste lowers the risk of cavities by approximately 24 to 25%.
Okay. Better than nothing.
And I would say in my experience, especially targeted high dose fluoride toothpaste in high risk individuals, I see that number higher. I think that number is probably just in the general population, who uses it, who doesn't.
And it's hard to get these big studies pulled together. I mean, these kids are probably like
well, how do you get these big studies together in an unbiased way?
Correct.
That's the hardest part with diving through all this stuff is how do you find people that truly want the best for people without being biased by the money involved in it?
It's definitely going to have to be philanthropic. I mean, you cannot have like big food, big pharmaceuticals, and then people investing into it and get an unbiased opinion. It's just not going to happen. What you got?
Looks like the pH of Dasani water usually lies around 5.6. It says the company's been adding minerals like magnesium sulfate, potassium chloride, and sodium chloride.
Okay.
Which don't show up on the nutritional facts when you look at the label.
Well, that's the other thing.
It just
they don't
says
have
water.
to say it.
No.
Like food and big food is huge in that. When it comes down to sugar and everything else, if it doesn't meet that specific range, they're not required to list it on the ingredients label. And that's confusing for people because it's just like, well, it doesn't have any sugar in it, but it's not because it's not 1 gram.
And I want to get into that in just a second.
Yeah.
One big thing from dental perspective, Dasani water is a pH of 5.6. Your mouth can only form a cavity when your oral environment is at 5.5 or below. Your body can, your mouth, the bacteria in your mouth are not creating decay if your pH is at 5.6 or above. So that's part of why acids are so bad for cavity risk.
Sure.
You're drinking water because you think it's healthy. This water is putting you 0.1 away from the level where your mouth can be creating decay all day long. One little orange slice, whatever, tips your mouth into a pH where now you're creating decay all day long.
That's insane.
Where water should be a pH of 7. 7 is neutral. So normal.
What is the pH of the mouth supposed to be? Do you know?
The mouth should stay at 7. Ideally, our mouth stays around neutral pH.
So basically, if somebody's swishing and swallowing Dasani, like they're increasing that risk.
You're putting yourself right on the verge of creating decay in your mouth at all times.
Well, the other thing too is just like I think the pH of the gut's roughly around like 3.5, 3.7. And like I've always been a big advocate of just like, okay, people ask me all the time with alkaline water and everything else. I'm just like, that ain't gonna do nothing. I mean, if you put your hand in your gut, it's gonna be gone. Meaning it's gonna go bye-bye. So like you can do alkaline water and everything else, but like it's different because a lot of people create that coat, not to mention secretions from the mouth and everything else to kind of keep it there. And now that pH is dropping, and like you said, it's a problematic thing. And I do know a lot of people, specifically a lot of people that try to increase their amount of vitamin C through liposomal form and powder form in drinks, meaning like ascorbic acid and those things. So we also know that. So I assume that's also a problem.
Yeah, the research is mixed on the alkaline water as far as tooth-wise, whether it is actually raising the pH. There really isn't a huge benefit to raising the mouth above 7, but for sure, staying away from waters that are putting your...
There's a better option.
There's a better option out there. So, Dasani, do better.
Yeah, no kidding. Okay, next. Well, the other thing too is like we talked about before. I don't know if we mentioned here or not, but I want to talk about nanohydroxyapatite as well as remineralization. So, like, let's just say somebody doesn't want to do that. Can we do things, and what's the efficacy of that versus fluoride?
Absolutely. So, nanohydroxyapatite, for those that don't know, it's a newer material, synthetically derived, that's designed to mimic natural tooth. So your tooth is made up of hydroxyapatite. That is what the enamel of your tooth is made of. So they've synthetically derived essentially the same material that tooth is made out of. And the research is very promising so far. Doesn't appear to be having the health negatives of fluoride. Still showing positives compared to 500 parts per million fluoride, which is the amount that you would get in your regular over-the-counter toothpaste. So if you get a fluoridated toothpaste from Walmart or Walgreens, they're very comparable. There isn't research that compares it to 5,000 part per million fluoride toothpaste that I give to my high cavity risk patients. So currently, the way I'm working with it is hydroxyapatite is awesome. If you're a lower cavity risk patient, you've got 1 or 2 areas that we're watching might turn into a cavity. Fluoride's more researched, but obviously showing a little bit potentially more health issues. So either one is great for low cavity risk patients. If you're a high cavity risk patient, you've got a lot of issues going on. I still recommend the fluoride, but I still got patients like, nope, I'm not touching it. I don't care if it's good. It makes me nervous to use it. Awesome. Let's use this hydroxyapatite. Is it as effective? Probably not. But it's one tool in our quiver to help meet you where you are. Because ultimately, my goal is to give you the options. My goal is to give you the ability to make an informed decision for yourself, and then work with you at that position that you're at.
I think as we kind of transition, Dr. Brock, can you look this up too? Like, how many patients, this is kind of a fun and soft topic, but how many patients hate going to the dentist?
All of them.
It's funny too. I
you
really
don't need to Google that. You can just ask the guy that's there every day.
Feels it every day, right?
I mean,
I don't know why. I mean, like, obviously it's your mouth. Nobody wants to have drills in your mouth and blah blah blah. But we need to increase the.
I mean, it's the number 2 fear nationwide behind public speaking.
Really?
Public speaking dentists. Last time I looked at it, Brock might have better information on that.
Well, this wasn't hard to find. I just had to say how many people hate, and then it popped up. But it shows that between 36 and over 60% of people experience some level of dental anxiety.
That's insane.
Yeah,
that's insane.
So it's a lot, and I deal with it every day, and that's actually what gave me a heart to pursue dentistry. My childhood dentist was not the greatest. And by not the greatest, I mean he's currently in prison for dealing heroin out of his dental office.
Wow.
So
that's a story.
That was where I came from. So
great story.
Not a great dental experience.
Yeah.
Lots of issues. The dental work itself was poor, and obviously he was doing some stuff out of the office that no one else knew. So I knew that I could do better. I knew that there's a way to do this a lot more gentle for people.
Yeah.
So my mentor told me early on, he's like, honestly, Justin, if your front desk is happy to see the patient, if you don't hurt them while they numb you, while you're numbing them, you're going to have a culture of good people. So, no, I hear it every day. Even though everything that we do is based around making patients comfortable, trying to create an environment that is as comfortable and peaceful and non-painful as possible. I still hear it 1, 2, 3 times a day of, I hate the dentist. Not you guys. I don't hate you. I love you guys. I just hate being here. every day.
I hate what you do. I don't hate you.
I hate what you do. I don't hate you. And that's our main goal
Sure.
is at the end of the day, my goal is to hear that wasn't that bad.
Yeah.
And I know I'm never going to be someone's like, I got a free Saturday morning. I'm going to head to the dentist and go get something done. I'm never going to be that person.
It's not a
But
spa.
everything we do, from the team I hire to the environment we create, is all designed around trying to alleviate a lot of that pain and fear, which is real in so many people. And I've been at my practice for about 10 years now. I love seeing the kids that I started seeing at 2, 3, 4 years old.
Yep.
And now they're in their teenage years. And if we have to do a filling or do something that is a little more uncomfortable, they just sit there
They trust
and
you.
they have zero fear in the world.
Yep.
Because from the very beginning, we were able to create an environment that wasn't terrifying.
Yeah.
And we've eliminated that dental phobia that's so prevalent in so many. So I love seeing that. Even my older patients that have always been scared, I love
For
them.
sure.
We see a huge difference in those patients that have been burned before, and for good reason. There have been some terrible stories that I've heard of offices they've been to and places they've been before. It breaks my heart when I hear those. But I love seeing those people 6 months, a year, 2 years, 3 years later, and just watching those walls kind of come down, and just watching them kind of walk in the door and not have that guarded wall up.
For
Just because
sure.
they know that they can trust us.
Well, it's just like anything else, and I think we as providers are always going to deal with the potential of somebody else's pitfalls, and that can happen to us as well.
Yeah.
So it's not like we're going to sit here and be like, oh, well, yeah, they shouldn't have done this, that, and the other, because it's going to make us look bad. We always need to go to bat for the people in our profession, because again, like, we are linked regardless if certain things are there. But I think in that same respect, I mean, I just heard of a surgeon, a GI, that was supposed to place a GI tube and placed it too low, and basically had to take it out, sew the patient back up, and say, sorry, I'm an autistic kid. So it's like one of those things where, like, these things happen even in routine procedures, but it's not to disqualify certain things. It's just certain things happen, you know?
Yeah.
And like sometimes, like, yeah, I get plenty of people where I might be doing like an ultrasound guided injection in their shoulder, and they feel that prick and that needle's not too small. And they're like, whoa, you know, like, but it's just like, it's part of it.
Yeah.
You know, if you explain things well, you create an environment, and the outcomes are still good, regardless if it's a little bit painful. It's just rapport.
Yeah.
I think like what's lacking in most professions now, and I hear it all the time, it's just rapport. The patients don't feel heard. The patients don't feel respected or cared for. And I think like what I'm hearing from you is your staff goes above and beyond. And I'm hearing that, and I'm seeing it in your own practice. So it's one of those good things. Now, I know one of those big topics that people talk about is the Goldilocks phenomena. The Goldilocks phenomena in this respect would be, is there a potential where specifically in dentistry, or, you know, it happens everywhere, we know this, are we over-treating? Are we racking up bills when we don't need to? And is that a potential? Do you see it in your peers? Do you see it? Have you done it? Like those things.
Yeah. I mean, it's huge. And kind of like we went back to, there are good providers in every situation, and there are bad providers in every situation.
Correct.
And so my goal in talking about this is not to rag on those who are doing their best. I'm not the only one doing what I do. There are good people with good hearts that care about patients, and I'd say more often are that way versus alternatively.
Correct.
There is a huge push to give patients the most expensive treatment, no matter what.
For sure.
That's often in the corporate dentistry side. I don't need to name names, but remember, a dental office is owned by a conglomeration. You lose a little bit of that personality.
Yeah.
And that's just what I found. Are there corporations that do great? Probably. But in general, we see it in that model where profits are what are tracked daily, not necessarily patient care, patient satisfaction. Those things aren't as well tracked. It's the dollar amount.
Yep.
So yeah, they're 100% are offices that are strictly about the money.
Yeah.
And they're offices that are only caring about the person in a way, but they're so compassionate that they're only offering the cheapest options to their patients.
Correct.
They're only offering technology from 20, 30 years ago because they don't want the patient to have to pay for something better.
Correct.
So I actually use the Goldilocks philosophy every single day of a
Yeah.
good, better, best scenario. Goldilocks obviously picked the one in the middle, right? But I want patients to know what their options are. And my job with almost every situation is there's usually more than 3. But it's figuring out, by talking to you, figuring out your wants, what your needs are, what are your barriers, figuring out which options aren't best for you, and then figuring out from there what makes sense for you.
Absolutely.
And letting people make that decision for themselves. Like you said, I want the best for myself, so I don't care what it costs.
Yep.
For someone like you, this is what's going to work best for you.
Yeah.
So that's really the heart of it. and how we try to approach every single day.
Well, absolutely too. And I think it's one of those things, just to revisit it, like the care that I got, like you just have to choose. And like you said before, like a lot of people are afraid to present care plans that are going to cost money, but are needed.
Yeah.
And you do yourself a disservice. Not only do you discredit yourself in your practice, but you do yourself a disservice because now the patient's not going to get better because you gave them a care plan that was a little less than what should have been done, and the outcomes are going to be a little less. And in hindsight, like you should have just done what you thought before and not have this like poor man syndrome or imposter syndrome that is placing you. Like just be who you are, do what you know is best, present the data. If they choose to do it or not, then you can talk to them about it, give them more options. And again, like to your point, like the human brain can only comprehend and compartmentalize 3 different things at once.
Yep.
So I think it's a beautiful option giving somebody 3 different options, least invasive, most invasive, somewhere in the middle. And, for me and my outcome, like I'm sure it wasn't most invasive, but it was perfectly good for what I needed and it allowed me to benefit further.
Yeah. Could I have given you a plan that was bigger than that? Sure.
Of course.
There's bigger things out there.
Of course.
But what did you need? You didn't need all the extra stuff. But one of my mentors, I remember, is a very powerful part of his lecture that he was giving. But he was talking about a case where the patient really needed an expensive procedure.
Sure.
It was a really invasive surgical procedure. But he said he didn't present it to her for the longest time because he thought that financially they couldn't afford it.
Yep.
And it was multiple years later. Ended up talking to him, had big issues later on down the road, couldn't chew the food they wanted, had debilitating joint issues, lots of things that came up over that time frame. And somehow, I forget exactly what he said, but ended up talking to the patient and saying, I wish there was something I could have done back then, and found out this person had all the money in the world, would have invested it if they wanted to.
Sure.
And he said, I took away that person's choice to say yes to the best because I thought they didn't want it. And so that's my main goal is I never want to take away someone's choice.
Don't
to
get
say
in the
yes
way.
to the best.
Yeah. Don't get in the way.
As soon as you say that's not an option for me, I'm not hurt about it. Let's find what option is good for you. That doesn't bother me at all. But that was powerful, realizing by me not presenting options that are viable for someone, you're removing that ability. And I never want to be that provider.
I mean, that's beautifully stated too, because it's just like at the end of the day, like good providers become mediocre providers when they stop believing in what they think and do. And I think like at the end of the day, a lot of people will do that, or they'll be handcuffed by big medicine or big dentistry or something like that, of like, you just need to check the boxes and that's it.
Yeah.
I mean, this is what we talked about before, being, Tennessee still being dead last when it comes to medicine and how we practice it and outcomes of which. And it's simply because of like, I mean, yes, there's rural stuff, but there's also like, it's cookie cutter. It's box. I mean, most of like, even your specialists are just like, is your blood pressure good? Is your diabetes in check? Do you have your cholesterol meds? And and it's not any fault of their own per se, because again, there's a massive shortage.
Yeah.
But when it comes down to it, at the end of the day, like we need to do more. We need to have better standard of care. We need to raise the bar, however hard that may be, for us to get out of the normity of what we've been doing forever. Because again, like if you don't, you're getting left behind. Somebody's going to do it. I'll come into Cookeville and do it. Like, I don't care at all. Like, and I like so many people I hear will murmur about what I'm doing and everything else. And they're just like, oh, this, that, blah, blah, blah. It's just like, I don't care what you say.
Yeah. You
can go ahead and talk to every one of my patients. They're going to come to your office and discharge themselves because they're unhappy with the outcomes you're giving them and happy with mine.
Yep.
And, it's one of those things where I'm not here to do that. I'm here just to maintain the bar, try to progress, try to look at the research. And like you said before, obviously research, you can find a to and fro every single time. And it makes it hard for us to look at that. But at the end of the day, the patient's what matters. And you need to be diligent, build rapport, make them feel comfortable, and create that trust that they know that your heart is their best expectation and their best option moving forward. So I think some of the other things is like, we know, and we've heard this for a long time, and you can kind of talk about this, but we know that like if a mouth is good, everything inside that mouth is good, systemically that patient will also be good. What do you got on that?
I agree. No. Next topic. No, there's so many areas that we can reasonably assume. You've got other things going on. My friend from dental school, we drove back and forth together every day. His dentist is one that found he had Crohn's disease.
Yep.
Inflammation in the body, which is
Yep.
kind of the big topic in medicine right now.
Yeah.
I see it in the mouth every day.
Uh-huh.
And if I see it in the oral cavity, there's something else going on in the body. You're putting pressure on organs and parts of your body that don't need to have that pressure on it. And no, there's no question that they're related. Is the mouth causing hypertension? Probably not.
Sure.
Is it one contributing factor to it? Probably. But they definitely play off each other.
What do you think about airway stuff? I mean, most people are like going into kids most of the time, getting these expanders, having their adenoids reduced or taken out, buccal ties, posterior and anterior tongue ties, all these other factors. Like, do you think it's being overdone? Do you think it's changing the structure of the face too much? Do you think it's playing into...
I don't.
No?
I think it's being underdone still.
Okay.
I think the majority of dentists don't understand the impact of sleep, especially in adolescence, and the long-term effects of the entire body. I see it in the mouth. When I look into someone's mouth, there are certain things that I see that show me either you've had breathing problems in your past, but even the way your face developed. Faces can develop differently if you've developed sleeping issues.
Correct.
In childhood, oftentimes the face is longer. Because the tongue is pushing up on the roof of the mouth and it creates that higher vault. The tongue doesn't have anywhere to go. When they're trying to take those breaths. But no, sleep is, I still think it's underutilized. I think the majority of dentists who haven't taken the time to look into sleep, if they see wear in the teeth, they'll say you're probably bruxing at night, which is nighttime grinding. They'll say you're a nighttime clencher, you're a nighttime grinder, here's a night guard. I've solved you. And now the teeth aren't touching each other. So maybe you're not damaging the teeth anymore. But if obstructive sleep apnea is the problem, you're still 4 times an hour, 5 times an hour, 10 times an hour, still mild.
Sure.
Moderate is what, 30 per hour? And then severe is, I don't know the number. When
it goes higher.
Severe
like
hits 50 maybe?
Yeah.
But mild is 30 per hour, which means every 2 minutes, your body is waking itself up to take a breath, because while you're sleeping, your body isn't breathing normally. So when that happens at night, your jaw pushes forward, and whatever's in the way, your body doesn't care. So that's what I see in the mouth, is I see flat tooth structures because you're breaking teeth, shaving down teeth, because every time you take that breath, that jaw is pushing forward. So the night guard they made is fine, right? Your teeth aren't breaking each other. But it's not actually solving the central issue, which is some sort of either central or obstructive sleep apnea.
Correct.
Where the body stopped breathing multiple times a night.
And it's funny too, because like I get it all the time. I have people coming into my office, and the big qualifiers for obstructive obviously have everything to do with, how many aptic events do they have in that hour? And do they have nasal polyps that is forcing them to sleep and be mouth breathers? Are they constantly having dryness throughout the mouth? Can we check the tongue? Can we check the buccal? Can we check all those areas and see, dental caries? Can we have more lack of lubrication and secretion in the mouth that's causing damage to the teeth because of this, and so on? And the same thing is true. I think when it comes down to it, yes, I agree with you. I think it's being underdone greatly. And I think that proper oxygenation is imperative. And heavily, though, with kids. In that same respect, I think in Tennessee alone, we know the allergen profile is probably the second in the nation where we're at. We live in a bowl. Everything settles here, none of the above. We have mold, we have mycotoxin stuff. We have all these other factors that play into how well people's sinuses are pushed up. And we're not just talking about tissue inflammation that's creating obstruction. We're talking about infections, strep infections that are undertreated, not treated correctly, because we do know in this area, a lot of people don't prefer medicine as much. They miss strep infections, which we talked about before in my last podcast with Pans and Pandas diagnosis. But when it comes down to it, you can tell, if your child is snoring and you know that, and you can see bags under there, you're seeing allergic shiners under their eyes, you're seeing all these other factors, we know definitively that child's not resting, and that is going to affect their development, even if you think they're on par. And at the end of the day, like you said before, my son, I know he's got some stuff. Every time he freaking cries, he's got the Rocky pull down over here. He had plagiocephaly when he was a kid. He had to wear a helmet, all those other factors, and we did what we could. But at the end of the day, it's one of those things where these things massively disrupt not only adult development, but child development. And it's just one of those things that needs to be looked at greatly. And, we also talked about too, where a lot of people just don't want to do the sleep studies because they know that they're not going to tolerate the mask, or if they have, 15, 30, whatever, 40 apneic events in that hour, like we know 50% of the time people won't tolerate it.
Yep.
And we also know that like people won't even give it a shot. I think now most people aren't aware that like there are wearables. I mean, like VirtuVox is a company that literally places the chip on your finger and that's your sleep study for the night, versus like a mask like they used to, or going to a sleep center. Same thing is true. We offer different ones that are handheld because they're easier. But in that same respect, like it has everything to do with figuring out airway. Is it there? How much is it affecting your mitochondria? How much is it affecting your brain? How much is it affecting your recovery? And what is that leading into all the systemic chronic, not infections, but chronic conditions that you're dealing with? So, I see it, you see it, it's needed.
Yep.
So, I guess, when it comes down to it, we know the kids need dentistry. Terrified of it most of the time.
Yeah.
What's your take on kids in dentistry? How important is it?
As far as what?
Just
like when should they start going?
When should they start going?
Yeah.
What should what should parents look for? Help the everyday mom and dad notice like when's the right time to start going? What should they be looking for?
Yeah.
When are problems occurring? What do those problems look like? And so
Absolutely. So the number one question I get from moms is, when should my kids start going to the dentist? And I would argue like they should go as soon as they'll go with you. As long as it's the right situation, right?
Sure.
I run a family practice. So we have kids, we have adults, we've got scared 40-year-olds, we have excited 7-year-olds, we have babies that are still latched to mom, right? So we try to create an environment that's peaceful for everybody, right? But ultimately, the more the kids see you doing it with a good attitude, not scared, not whatever, like you're not handing those things off to your kiddos. So we have moms all the time. Little 2-year-old is sitting on their belly watching mom get a cleaning.
For sure.
And they're peeking in and seeing what's going on. So when it comes to be their time, they're like, oh,
I can do this.
I can do this. I have no issues. So we definitely want to see kids early on. We do something called a fun visit for kids' first appointments if they're under 5 or so. But the plan is to not do anything. We sit them down in the chair. We let them push the buttons. So the chair goes up, the chair goes down. If they let us brush their teeth, we let them.
Yeah.
If they're kind of fighting it, don't touch it. Show them the air water syringe, show them the mirror.
Make it fun.
I mean, we push it as far as they'll let us, but as soon as we hit any feedback, we're like, all right, we're done. And the kid leaves thinking, that was it? I sat in the chair, went up and down, and I got a toy from the treasure box. Like,
it was a good day.
I can't wait to go back. So we created that. But as far as parents, what can you be doing at home? You need to be brushing your kids' teeth way longer than you think.
They do.
Parents need to be brushing their kids' teeth way longer than they think.
Yeah.
Back when they used to teach cursive, they used to say, once your kid can write in cursive, they can brush their own teeth. No one learns cursive anymore. I guess my kids are learning it, but no one learns it anymore. Honestly, till about 10.
Yeah.
And even then, when my kids got to that age, let them go. And every once in a while, I'd kind of take a peek and be like, back in the bathroom. I need to help you out again. You missed a couple spots. So brushing their teeth way longer than you think. When it comes to the fluoride that we were talking about before, one of my favorite tests to see, because one of my favorite applications of fluoride is ACT, mouth rinse. The main reason is there's a reservoir at the top, so you can't just drink it. One of the biggest things is toxicity, drink too much.
Sure.
There's a reservoir at the top, so you have to take the cap off, you squeeze it, and it fills up the reservoir, but you can't get too much. So it prevents the toxicity because it only goes in that reservoir. So it decreases the chances of that. But my favorite test, when kids are ready for that, is parents take a little Dixie cup, a little paper cup, put a mark of Sharpie on it on the outside, and then fill the water up to that spot. Have your kid put the water in the mouth, swish it around, and tell them to spit it back out.
Yep.
They can't rinse until they fill that cup back up to the Sharpie mark.
The line.
If they put a little bit out, they swallowed the rest. They're not ready for fluoride rinses. They're swallowing it. They're ingesting it. Stick to toothpaste and stick to other stuff.
Yep.
So don't give them any rinses of any kind until they fill that cup back up. And we always play that game of what do we do with baby teeth, right? I hear all the time, it's just a baby tooth. Just let it rot, let it fall out. What's going to cause the big issue? But ultimately, those baby teeth are setting the foundation for the permanent teeth. Those baby teeth are holding the space for that permanent tooth to come in its space later on.
Sure.
And if there's severe decay or breakdown, same thing we talked about with missing a permanent tooth, those teeth will fall into place. And now that permanent tooth doesn't have anywhere to go.
Yep. Now
Now that arch starts to constrict. When the arch starts to constrict, there's not as much room for the tongue. Where's the tongue go? Tongue goes back. Start having issues with sleep.
Yep.
So it's holding the space for the permanent teeth. Now, do I treat every cavity to baby tooth? No.
Yeah.
Just last week, patient in, they're a year away from losing their baby tooth, and there's a cavity forming.
Yep.
We're going to leave that thing alone, and when you take it out, there's going to be a little black spot on it. Tooth Fairy's going to take that away just the same.
For sure.
Hopefully she still gives you the same amount she gave you for that last one that didn't have a cavity in it.
Or more, right?
But ultimately, they're placeholders for the permanent teeth. The bacteria that they're forming in that primary dentition with baby teeth are similar bacteria that are going to carry into the rest of their lives. So keeping things healthy in that environment is of the utmost importance. So that's where I stand on kids in dentistry.
There you go. It's good. Dr. Brock, tell me how many people or how many kids are receiving dental care per statistics?
Oh, you want to take a guess on that before he gives the answer?
I want to hear it, yeah.
I think it's less than 20%.
You think so?
Nationwide.
Let's add a categorical age once you get the answer. I think it's 35%.
So in 2019, 86.9% of kids aged 2 to 17 received dental care.
Really? What's the source on this?
You
can look at that.
That's baffling to me.
That is baffling.
Looks like CDC data.
Oh, I can't trust that. Just kidding. You didn't hear that.
They might know what they're talking about. No, I mean, that's way higher than I'd expect. So I would wonder what that's specifically going to, because I know that there are drastic amounts of underserved groups of people that have never.
I think maybe the public health initiative and stuff like that is probably helping with that, but still.
Yeah.
Yeah, I wouldn't think that at all, because dental insurance is one of those things that most people don't have, and they don't really seek it out because
that might need a little deeper dive.
Yeah, we'll have to
and I know that there are a lot of schools will have an in-school sealant program. So in the schools, the kid's never seen a dentist before.
Yeah,
but someone will come in and put sealants on teeth just to help protect them. So it may refer to anything, but we could do more research on that later.
So talk about the adult. So we know the worst thing a patient can hear is you need to floss.
Yep.
So let's talk about flossing. How many times should an adult see the dentist? What things should they be paying attention to? How can they best help their mouth? What pitfalls are they going to run into with specific foods or whatever it may be? And then just help the normal human. What should they do? What are the recommendations based on what you know? Obviously
the old, I can still see the commercials as a kid. Brush twice a day, floss once a day. Absolutely true. Biggest thing I see is your number one goal is to remove the biofilm from your mouth.
Yep.
Within minutes of brushing, the biofilm starts building up again. If you're brushing well and brushing effectively, you're getting that biofilm off. And the main reason for that is your saliva has calcium, phosphorus, all the good things that help your tooth remineralize. If you've got biofilm, your natural saliva can't get to the tooth.
Sure.
So now bacteria can sit on the tooth and your natural saliva flow isn't actually washing that away. Over time, 2 weeks roughly, that soft biofilm turns into hard tartar. Most people get it right underneath the tongue on the inside of the teeth there. Most people get it there. But that's where the primary salivary duct is coming from, is under the tongue. So that's why you build it up there first.
Sure.
It's the closest to where one of the main salivary ducts are. There's many different salivary ducts, but that's one of the main ones. So brushing and flossing is designed to get that biofilm off, to let your body do what it does.
Sure.
Obviously, we live in an era where we're consuming way more than what the body is designed to resist.
Yes.
We consume so many complex carbohydrates, so many things that increase your cavity risk. That's why we're having to add all this stuff in. If we could go to this perfect diet that doesn't have all these sugars and carbohydrates, we wouldn't need to be having this fluoride discussion quite as much, because the cavity risk wouldn't be there. We wouldn't have this root canal discussion because cavities disappeared. So
be there.
Ultimately, that'd be the best answer is change the food. But until we get to that point, that's what we're struggling with.
Yeah, it's going to make it hard too. And I think and just for good notice with the fluoride stuff, obviously it's not really indicated for somebody who has Hashimoto's.
Correct.
And we know that that could be problemsome. I have Hashimoto's and I've been dealing with it for a long time. And just for clearance within that, we know that Hashimoto's is not a thyroid disease. It's an autoimmune condition that affects the thyroid, meaning it's an immune system dysregulation or reactivity to which. And I think the big thing when it comes down to it is a lot of people just don't know, meaning what can harm their thyroid if they have that issue, or what other things can hurt it within dentistry. So I guess my next question, you may or may not know, what types of things have you heard in dentistry other than fluoride could potentially hurt other chronic conditions, if any? If you don't know any, then...
So there's a lot of things that we run into as far as allergies. I know you've talked about that before.
Yeah.
There are certain dental materials that have cross-reactivity with allergies. I know certain like fluoride varnishes.
Yeah.
Like it's not the fluoride itself; it's the way the varnish is created. Has cross reactivity.
Yep.
With like milk allergies,
Yep.
strawberry allergies. There's a lot of stuff that has cross reactivity there. Ultimately, most of the things that we use are pretty inert.
Yeah.
Because the materials that we're using, when placed in the mouth, don't have any issues reactive wise. The things that we, for the most part, have issues with are the consumables, right?
For sure.
Designed to help stop cavities, but that isn't necessarily the restorative side of what we do.
Correct.
And obviously, latex was a big one, but latex is pretty much out of dentistry completely.
Yep.
I had a box of latex gloves show up at one point, and I was like, where did these come from? But I was putting them on, I was like, these feel awesome. They felt just like the old latex gloves. I was like, oh, I feel like I can do everything. Long. And my exact words were, these feel like latex. And I pulled out the box, and I was like, shoot, these are latex. I got to throw these away. I can't use these anymore.
Man, that's funny. No, so like, I guess just for the audience, like what we're talking about with cross-reactivity is there are certain molecular processes, specifically DNA structures, that can be found in food, that can be found in substrates, meaning like dental materials, whatever it may be, that can cross-react with what our body is, such as like, for a good explanation, since we kind of talked about thyroid, would be like, we know gluten's molecular structure specifically is inertly close to thyroid proteins. We know it's close to cerebellar proteins. So whenever we eat gluten, there's a potential that every time we eat it, our immune system will react to the gluten, but it also react to our thyroid, meaning it will kill the thyroid tissue. Same thing is true for cerebellar tissue, and this is why we can diagnose somebody, like if they have undiagnosed celiac, or if they have a morbidity in the sense of having celiac or gluten sensitivity with Hashimoto's, which is kind of correlative, the sensitivity that is. You'll find that if they just consume like heavy amounts of gluten, their thyroid's going to be hurt and destroyed, but then they're also going to develop the potential of cerebellar ataxia. It may not be overt, and it may not be like SCA or spinal cerebellar atrophy, but it's going to happen, and I've seen it before. And these things aren't psychogenic as well, because there's plenty of people that will say, like, this isn't real, this is a functional neurological disorder. It's like, no. Yeah. You can do an MRI, and you can look at the blood flow strains, and you can actually see the degraded change to the vermis and the flocculus and all the parts of the cerebellum. So in that same respect, like, it's one of those things where we do know that within molecular mimicry, it may not be the only cause for Hashimoto's, but it's something that needs to be brought to attention, right? And like the same with fluoride, the same with other things that can worsen conditions. And
with your Hashimoto's patients, are you telling them about staying away from fluoride? Are you giving them, like, what is a Hashimoto's patient that comes to see you? What kind of advice are they getting?
Yeah. Well, specifically, like, depending on what's going on, we have to kind of categorize them of where they're at. Are they in euthyroid 6 syndrome? Is there something in their immune system causing them to, attack their thyroid, have their immune system be a little bit reactive? We know that COVID spike proteins lay in our body within 8 months after the co-infection, and that's going to cause some immune reactivity, meaning like if there's antibodies to your thyroid globulin antibodies or TPO antibodies, those things are going to raise.
Yep.
And those antibody levels do raise based on irritation from viruses, from stress, adrenal stress, gut issues, liver stress, all these other factors that are relatively close to control. We can't control all of them.
Right.
But that's where we start. So like we have to figure out where they are at in that landscape. Are they like in the second or third decade of life and the autoimmune process is really whacking their thyroid? Then yes. I mean, like I'll utilize things like low-dose naltrexone as an immunomodulator, not an immunosuppressant. And that's different than naltrexone. A lot of people in the medical community be like, what are you doing now? Because naltrexone is obviously used for alcoholics, but in the same respect, low-dose naltrexone is a compounded substrate where then I still have to be careful with what's compounded from the pharmacist or what they're compounding in there for cross-reactivity.
Right.
But that can lower their antibody levels, and it can stop not all, it can't stop, but it will down-regulate the speed in which that autoimmune process is happening. And I think in the same respect, like it just helps us clinically treat that person. So when it comes to dietary stuff, I'm always staying away from 5 different things. Most people don't realize that iodine in somebody with Hashimoto's, high antibody levels and so on, can actually be worse for them. Now, we know iodine is a cofactor that can help thyroid function in general. Right. But we also know that if you give somebody with Hashimoto's or high TPO antibodies iodine and their levels are fine, one, if you give them high amounts, that iodine is going to create more damage simply because TPO is needed in the conversion of T4 to T3. So if we upregulate TPO because we give somebody iodine, well, now we're anti-TPO is coming in and killing that on the back end. So we're causing more damage to the thyroid. The same respect, gluten, molecular mimicry stuff we talked about, dairy, needs to be taken out because it's inflammatory period. We're the only mammal to drink another mammal's milk. It's kind of weird. Iodine-containing foods, high amounts of eggs.
Would you take it away from everyone if you could?
I would say there's not a whole lot of benefit, even from the calcium standpoint. I think that's propaganda from the farming industry. Like, leafy greens have way more calcium than milk.
Okay.
Right? There's obviously protein, and obviously that's not every case. I can't say for every case. But I would say, like, the inflammatory byproducts that are there, specifically the proteins, like, that our gut cannot degrade, like the casein and some of the other pieces that are in there, those cause chemical reactions in our gut that creates more inflammation. And if that inflammation is there, and every time you do it, it's not just you have a lactose allergy,
right?
Or you have it's farther than that. It's deeper than that. And like most providers, conventional medicine, it's just like, you don't have an allergy, so it's not a problem. You don't have a lactose issue, it's not a problem. Drink milk. But it's just like, you never went into sensitivity. You never went into the variability of the diet to see like what other factors are causing this to be so sensitive, and you never checked the gut. So like, you can't just say it's good for that patient, because if they, like me, like, I may not respond to gluten. I know gluten is going to hurt me, but every time I do any form of dairy, cheese, yogurt, whatever, I get mucusy immediately.
Yep.
And I'm just like, I'm not doing it, because this is creating an immunological response that I can overtly measure.
Yeah.
I don't have to have labs. So
we don't have to alienate the entire dairy industry in one moment. So
no, I mean, like it's, and trust me, like there's plenty of times where those things are needed. I mean, cachexia is a real thing, proteinemia, all the above, sure. But in that
what was that first one you said?
Cachexia.
What is that?
Like cancer, weight loss, and stuff like that. So like somebody who needs weight needs to put on heavy amounts of weight, because like a cancer patient getting chemo.
Because they're going to lose all that later.
Yeah. So like, I don't honestly at that point, like you need nutrition, you need whey, you need this, you need that. So like that's going to be more helpful as like a mass gainer versus something else where like, radiation or chemo is just like withering them away. They don't want to eat whatever. We have to give them something. And the same thing is true for the elderly, right? We know protein derivatives is an issue, and milk is decent when they can't chew.
Yeah.
They may not have teeth, right? But, I digress on that. So I think like, as we kind of pull everything together, what would you like to say to the audience when it comes to like, how can somebody look at dentistry and see it as something that is a necessary mean to good health? Yeah. What things can they prevent if they choose that route, psychologically and physiologically? And why should they come see you?
Gotcha. Well, I'm not the only one, but my main goal is health, obviously, for everybody.
Yeah.
One of the biggest questions I get when patients are, say, leaving our town, they're moving somewhere else, say, how do I find someone like you? And that's hard.
It's hard.
I don't have a great answer for you. One of my favorite questions, not doable for everyone. Mm-hmm. If you're moving to a new town and you're looking for a new dentist, call one of the specialists, root canal specialist, oral surgeon, whatever. Find the one with the best reviews.
Sure. Ask
them who they should go see.
Yeah.
Because that specialist sees work from every general dentist that comes to them.
Mm-hmm.
They see the work that every dentist does, and they help take care of those patients. They know what kinds of cases are getting referred to them, which ones aren't when in that process. So
it's good.
Not that that's always doable, but I think that gives you a great insight, because specialists are uniquely able to see what the skills and abilities are of the providers. So that's one factor.
Yeah.
Finding someone you're comfortable with is the number one thing. I'm well aware that I am not everyone's dentist, and that's okay. There's someone else that they're comfortable with, and I want people to find who they're most comfortable with, because ultimately the majority of dentists are doing the best that we can.
Yeah.
With the information that we have, the skills that we have, the shortages we have nationwide, there's a shortage of team members.
Yeah.
Fortunately, I have a wonderful team that we are not hiring. So
it's good.
When everyone found out I took my team to Costa Rica this year, everyone's like, "Oh, are you hiring?" No, it just came with the girls that we've got. We went to Costa Rica, but
it's good.
Finding someone that you feel comfortable with and really gives you the ability to take care of that. Ultimately, whatever you're doing at home, as long as you're doing it, is good. I hear all the time about oil pulling,
not swallowing,
Definitely spitting it back out.
Yeah.
But my perspective is, how long do you have to oil pull for it to be effective? 20 minutes?
Yeah, it's a long time. Nobody wants to switch that.
If you're going to put 20 minutes of care into your mouth, let me show you how to brush and floss your teeth for 5 minutes a day. Mm-hmm. You get 15 minutes back, and I'll get you the similar results. So I don't think there's anything wrong with oil pulling.
No.
I think it's just we're kind of fighting the way that it used to be for something new and different and whatever it is, when if you put 20 minutes into your oral hygiene regimen per day, most things are good. Now, granted, gets to that point of susceptibility, like we talked about before. If you have higher levels of P. gingivalis, you're going to be more at risk for gum disease.
Mhm.
Brushing and flossing may not be enough, and that's what we're here for.
Yeah.
We're here to help when what you're doing at home isn't enough.
Yeah.
The majority of my patients, I would say, are doing enough at home to prevent disease. And every 6 months when I see them, my hygienist takes a look, I take a look, everything looks great. We high-five each other, we walk out the door and say, "You're great.
Yep.
Good to see you."
Yep.
Those are my favorite because that's easy.
Yep.
What you're doing at home combined with what we're doing in the office is working for you.
Yeah.
In most cases, if that patient stops seeing me,
Yep.
things will start to get worse.
Yep.
There's some patients that even though we're seeing you every 6 months, it's not effective. We have to do something different.
Yeah.
But the normal home routine, brush twice a day, floss once a day.
Mhm.
Why see me? I got a great team, honestly.
You do.
Everything that I do that's different is because my team is so highly skilled. I couldn't do what I do without them. So I spend a lot of time learning and a lot of time doing those things, but the ability for me to take what I learn at these CE courses and pass them on to my team, and they take it and they run with it. Their hearts to care for patients. They know every person that walks through the door.
Yep.
And 2 weeks ago, our server was down, so we had no
Yeah.
information, no notes,
worst.
no pictures, no nothing.
Yep.
My front desk girl knew every person walking in the door,
It's important.
knew who they were, knew what they were coming in for. They just have a heart for people.
Yeah.
And that's our passion, is to
Yes.
care for people, to meet people where they are and help them either get better or
Mhm.
stay better.
Yeah.
So that's what we do.
That's wonderful, man. No, I mean, to be honest with you, I've enjoyed being in your practice. I've enjoyed having you on the podcast. Hopefully the audience will learn so much. I have. And at the end of the day, too, we have to understand that, too, dentistry is a beautiful piece of health that is probably underserviced by most people.
Mhm.
And I think if we just create that bridge and help them understand a little bit about good, bad, and different about it, honesty, and then having a facility like yours that is welcoming and explains things and really provides a care plan that's perfect for that patient. It sounds like it'd be an easy thing. It's not.
No.
But you do it well. So either way, thank you for coming on the podcast. Before we jump off, just where can people find you? Do you have any socials? You can give your phone number if you want. It's up to you.
I'm not a socials guy.
That's good. It's okay.
I drift off into obscurity. There is an Instagram, I think. My
Mhm.
wife handles that.
There you go.
But it's mostly just highlighting my team and how great they are. So Slager Family Dental Care in Cookeville, Tennessee is where we're located. But if you want to try to find me online, good luck.
We'll find him.
I don't know if I'm on there.
You are. All over, right? It's good. Well, thanks, brother. We appreciate you. And we are signing off. So hope you guys enjoyed that podcast. What we're going to do is ask some Q&A questions, and I look forward to it. So thank you again for being here.
Absolutely.
We'll see you in the next one.